Hi, everyone. Welcome to our monthly webinar on trending beyond COVID-19. Today's topic is on the cost of COVID for employers. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare. Thanks so much for joining us. If it's your first time, we're glad you're on board. And if you're a regular visitor, we're glad to see you back. It seems like it's been quite a while since the last session, since it was in early September. The session is being recorded. During the webinar, you'll be on. Please submit your questions using the Q&A function in Zoom. I'll be moderating the questions. The webinar recording will be posted on our YouTube channel, and a transcript of the questions and answers will be posted on our website within the next few days. Alexis will share the links with you during the session. We have a full hour scheduled, so there should be plenty of time to answer your questions. As always, our speaker is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and an Associate Medical Director. He's also our lead clinician for WorkCare's COVID-19 response. So I'm excited to turn it over to him. It's been a while since we had a chance to catch up, so I look forward to hearing what he has to tell us today. Thanks again.
Hello, everyone, and welcome back to another installation of our Trending Beyond COVID. I am Dr. Anthony Harris talking to you now. Unfortunately, Karen lost her Zoom connection here, so apologies for the slight delay in getting started, but we are going to go ahead and get started here. And we'll be talking today, obviously, about COVID as it pertains to the real cost of COVID. This is part one of at least a two-part series. And today we'll be focusing in on the framework in which we should be thinking about how we're managing our COVID in the workplace strategies to help prevent transmissions, as well as ultimately costs to our institutions, to our businesses. And so we'll jump right into it, beginning with our typical framework, which is associated with this rubric here. Starting with the clinical business case, right? What are we trying to suggest and get at in terms of our recommendation from WorkCare in regards to how you should be thinking and acting to help mitigate risk? And then we'll talk about the drivers, the causal examinations of what we're referring to in regards to trends. And we're going to provide some thought leadership around the topic, in particular, in this case, obviously, how we should be thinking about our risks and managing downstream risks that we may not be cognizant of today. And then finally, the last three, trending the pandemic, is going to do a deeper dive into some of the trends we're seeing in the workplace. We'll talk briefly about the mechanics of the fix, right? And in this case, we'll throw in a little curveball and talking about what not to expect regarding the fix. And we'll finally end on messaging to our population. How do we approach our communications with the workforce so that we get the best buy-in with the strategy that we've elected to move forward with corporately? So without further ado, let's talk about balancing the short-term and long-term risks, mitigation strategies with mandates. And we know that mandate this day and time is kind of a dirty word, right? In regards to engendering big reactions from some. And we want to make sure that we are clear, we're not associating this terminology with a governmental mandate, but rather, what do we recommend and what should we be thinking in terms of mandating in the workplace a particular strategy? And that's it. At the end of the day, We're responsible for the health and wellness of our employee population, and that's going to require us to make some mandates. And it's not necessarily what you're thinking in terms of absolutely mandating the vaccine, but we need to know what we should be considering in regards to how to keep everyone safe and mitigate risk, as we're talking about specifically in this presentation for the business itself and for the workforce. So what are the corporate mandate? Can corporate mandates be the best strategy to ensure overall corporate well-being? So why are we talking about short-term versus long-term strategy in the first place, right? The question begs, hey, Harris, why, long-term, are we going to be dealing with COVID long-term? And if not, why even bother of going through the process of this train of thought? And so we want to jump into that because last time we presented the Delta variant and the impact it has had globally, now ubiquitous in every country just about, and we know that it's in every state and every city in the US, right? And so we need to know exactly where we're heading and for how long we're going to be in this. And we can point to some definite changes in the virus itself that's going to undergird our previous prognostication that we are going to be dealing with COVID for some time. On average, the timeline is about 5 years, right? In terms of what most are thinking in the clinical and scientific community. So we want to talk about what's driving that in terms of successive COVID variants. We've talked about the Lambda, Mu, certainly Delta, right? But when we talk about the evolution of the virus, we know in evidence that it's becoming more and more airborne, right? We know early on in the pandemic, we thought, all right, these the infections, this is late 2019, early 2020, the infection is spread by respiratory droplets, right? And that was the reason for making sure we were social distance 6 feet. Now we know, we learned later in the pandemic last year that airborne illness is a predominant means of transmission, meaning that the droplets are 5 micron in size that contain the viral particles and can hang out in the air for 3 hours or longer, right? Hence the need for mask mandates to help decrease the burden in the air of these potentially infected particles. And what we know now is that the virus continues to evolve and become more and more easily aerosolized in regards to an infectious droplet, right? And this research that was published just in September of this year, this is an accepted manuscript. We know that in here, the key to the success of the virus and being more easily transmissible through airborne droplets is the amount of virus actually contained in the droplets itself. So, and over time, we've seen a heavier burden of the virus in each droplet, and we know that it's continuing to increase with successive variants that we've seen, right? And so we need to, one, know this, and two, know that because of this, we're not going to we're heading the wrong direction for getting rid of COVID in that regard, right? If we go a layer deeper, we can see another reason why we have this phenomenon of not just more easily transmissible illness through droplets, but also illness that's causing more disease more quickly in populations. And this is a breakdown just for means of example, all the genetic variability that we've tracked just out of one state in Oregon, right? This is not including all of US. This is just in Oregon, Oregon State University tracking this data from over 4,400 genomic samples that have been taken and analyzed. And we see on the left-hand side where those where the distribution of these variants and these genetic mutations have gone to, and also on the right side here, we can see the lineage. So we're not going to dive too deep into breaking down each one of these branches in the lineage called the phylogeny of the virus itself, but I want to point out that this virus continues to mutate and continues to have genetic variability at a tremendous rate that is causing it to be a likely staple in our communities for years and years to come, right? And so when we talk about the impact of Delta, we know that it's caused the spike that we've seen recently here in the US and globally, and we need to know what's coming down the pipe, right? So this is a little bit alarming even to me in terms of this research pointing out that yes, Delta has a lot of genetic variability, but now there's a Delta plus, right? A Delta plus variant, which has some unique properties. In particular, the Delta plus variant has a significant higher number of prevalent mutations, up to 20% more than the original Delta variant. Okay, so we already knew that Delta variant had mutations that caused it to be more easily transmissible and cause more severe illness and escape the immune system more than the Alpha variant of old, right? But now we have a Delta plus that has even more mutations and could be associated with why we're seeing why we saw recently the increase in burden of illness here in the U.S. In particular, also this particular variant has a higher number of mutations in the spike protein. Again, the spike protein is how the virus gets into our cells. And it also has a isolated mutation in a location called the ORF1A. Is that at the end of the day, that's just how the virus itself codes for its own replication, right? And it's more prevalent, 58% in the Delta plus than the native Delta variant. What does this mean? At the end of the day, this means that structurally, this virus is conforming to evade our antibodies and have a weaker interaction with our antibodies, meaning that we're not going to be able to as easily fight it off if we should come in contact and contract it, right? And so again, pointing out, this is part of the reasons why we'll be dealing with COVID from now until the next 5 years and probably long after that, and why we need to be thinking long-term about our strategy to deal with this illness and the impact thereof on our workforce, all right? And as we talk about then the causes for these trends in regards to our decision-making, why we have to consider these different changes for our strategy, it's twofold, right? We have market pressures and we have governmental mandates, right? And we want to speak to these briefly. We all know the governmental mandate, right? If you don't by now, we got to wake you up a little bit here, because the Biden administration back in September, since the last time we had this presentation, announced that we're going to hold accountable employers to make sure that either one, your employees, if you have more than 100, are vaccinated, or they're tested on a weekly basis, right? And we know that this mandate rolled down to OSHA in order to execute on penalties that can be as high as more than $13,000 per instance in which you're not conforming to this mandate. And we're still waiting to hear whether or not this executive order is going to hold up finally in all states. But we already know that employers are making inroads to being prepared for this, as well as those who are government contractors and recognize their inability to get out of this mandate, even if there is some changes to how private industries that do not interact with government contracts can be impacted by this OSHA and the OSHA mandate, as well as executive order. So when we talk about, obviously, for more information, go to the White House landing page here, and it goes into more depth into this mandate. We won't go through, for the interest of time, all the particulars, but I'm certain that many of you on this call are already familiar, because this has been the big deal for several weeks now. So let's talk about another trend here that we mentioned before, right? And this is, again, some of the undergirding and cause of why we have to be cognizant around our strategy to shift and be nimble in our strategy. And we talked about brain fog previously, right? The phenomena of individuals who contract COVID and resultantly have the fogginess of memory issues, have issues of cognitive ability, right? And we talked about even the impact this may have to our employees to the tune where it may become a fitness for duty issue, right? And so again, 40 up to 40% of people being affected by this brain fog who have contracted COVID-19 to some degree. And this phenomenon we know can last in some people up to 3 weeks, or excuse me, 3 months after infection. And we know it can be very impactful from an anxiety and depression standpoint as well. And we know that the pathology behind it, as we presented previously, was caused by these cells called megakaryocytes getting stuck in the blood vessels of our brain. So there was an organic reason associated with why brain fog was an issue. Now let's expand this to what we know today, which is somewhat disturbing again to me as well, which is preliminary research finds that even mild cases of COVID can lead to marks on the brain, unclear as to how long it may last, but evidence is showing that COVID-19 infections affect the brain and to the tune of cognitive impairment in some cases, right? And when we talk about and break down then this phenomenon and this trend and the research that we're seeing, it points to a couple things. First, brain changes associated with the infection on MRI is what the research methodology was. 785 adult participants. The reason why they were able to conduct this research, just to give you a little background, is because the UK, in this case, where this study was conducted, surveyed over 40,000 individuals prior to COVID-19 pandemic with MRIs, right? MRIs of the brain. When they looked at the brain in a couple modalities to understand, and it was a separate study trying to understand brain function. And so what this research group was able to do is call on a subset of those 40,000 individuals, in this case, 785 participants who already had quote unquote baseline MRI brain studies. And they were able to study these individuals who had COVID, and including 401 adults who tested positive for infection, and before after their original brain scan before the pandemic, and then look at the changes of their brain over time compared to those individuals who did not have any evidence of a COVID infection in between their original brain scan and the brain scan that was done by MRI in this study. And that was about 384 individuals that were in that control group. And so what did we see in terms of, and by the way, they were able to match the controls with the experimental group so that there were minimized bias in terms of other reasons for the changes in the brain. And so what we saw, again, something that was a little bit alarming, and we'll fast forward here in the interest of time, is that in this group of individuals, over time, we saw, because of COVID, and they identified 67 to 68 individual changes in the brain, right, collectively, in this 401 adults. And we won't, the paper goes into more depth. We won't go through all 68 and 67, 68 changes, depending on which methodology they use, hypothesis-driven versus exploratory approaches. But we want to point out a couple because they're important to know that it's going to impact our workforce potentially here for some time. That gray matter thickness was affected. The gray matter is a layer of matter in the brain that is associated with our cognitive ability, okay? And we know that in this study, individuals who were infected with COVID had a significant decrease in the thickness of that gray matter, right, in certain areas of the brain, the lateral orbital cortex. We won't go through all of these different parts of the brain and the relevance, but we know that overall, there is clear evidence for not just specific areas in the brain that were affected, but a diffuse impact of brain functionality. And that's connected with several other aspects of the brain. In particular, the global effects that we saw were even the volume of the brain itself, meaning that individuals had atrophy of the brain compared to, in the experimental group, meaning they had COVID, compared to those who didn't have COVID, right? So this is preliminary research, man. We're going to see a lot more of this research coming down from neuroscience investigations, but we want to be cognizant of this because, again, burden of illness is what we're after in terms of identifying our risk and our costs to the workforce and how best to mitigate. Again, we're talking this time about the framework in which we should be thinking about mitigating risk for our workplace, right? And we got to expand our thoughts around this, and we'll talk more about how in particular shortly. So last time we met, we spoke to the 7-day case rate per 100,000, in some states being as high as 550, over 550 to 680. Okay. If we fast forward to today and look at it a little bit differently here, data from CDC, the level of community transmission is depicted here in every state except for two, right? Being in the high category, right? And so when we talk about the high category, breaking this down into cases per 100,000 over a 7-day average, we're looking at over 100 cases of transmission per 100,000. Okay, and so this is alarming from the standpoint of, this is where we were. Last year, we continue to see some downward trends just in the recent weeks, and we'll talk about that here in a second. But as of right now, there is no state that's not at least at the substantial transmission level. Okay, and so when we zoom into where we were last month at a case rate per 100 per million individuals, we saw that the U.S. and the U.K. were neck and neck on a 7-day rolling average. And fast forwarding to today, the U.S. has seen a decline in the 7-day rolling average for per million, just at about the 300 mark here. UK saw a decrease and then another increase again, and we'll continue to watch that to truly understand why the UK had that bump there, and should we also consider that we're going to experience a bump. My hypothesis is yes. And next time we'll speak to more of what may be the drivers of that. But we'll continue, like I said, to watch this and see where we stand. In terms of the effective R naught number, right? We looked at it last time and we saw where the US stood in terms of the reproductive rate, how many individuals are infected by one person with COVID. That has gone down since last month. That's a good trend, obviously, below 1, meaning that our rates are dropping and not increasing. Anything above 1 means we're on the increase. And so this is another metric to identify how we're trending in regards to our management of COVID or dealing with COVID in the US. This is an R naught comparison between countries. I wanted to demonstrate this because we want to next talk about what may be the driver behind these R naughts. And the question, I think, has been answered many times over, that the driver behind this is, in fact, the Delta variant. And this is a representation of the percentage of Delta variant in the last 2 weeks represented in these particular nations. We're right up there at virtually 100% of cases now being all associated with the Delta variant. So we haven't seen a significant increase thus far in Mu and Lambda, which we know are not as easily transmissible. We're still dealing primarily with Delta, and like I mentioned before, Delta plus being likely a substantial impact there. If we look at case fatality rate now, as of today, it's remarkable that the US is on top in terms of case fatality rate, right? And this, I believe, speaks to, in part, our vaccination success compared to, for example, the United Kingdom, which has a higher number of individuals vaccinated, at least with 1 dose, right? And so we'll continue to watch this case fatality rate as we look at another metric here in terms of vaccinations. Like I mentioned, UK having a substantial number of individuals, over 70%, at least with 1 dose vaccinated, Canada and Italy as well, right? And you can see where we are in terms of US, and we'll break down those numbers more fully here in a little bit. If we now jump to fully vaccinated individuals, we drop down here, obviously, but we were above 64, at least 1 dose, we dropped down to mid-50s in the US, but UK is still around that 65% mark. And again, that can speak to, as we spoke to last month, their experience of lower mortality than we experienced here in the US. Deaths per million, we talked about last month on August 31st. This is where we stood, the US compared to UK. And we have gone up since then in terms of deaths per million. But we expected that because of the 30-day lag between deaths and incidents, right? And so we'll continue to watch the recent decline in deaths, and hopefully it continues to go down as we would anticipate with the case rate going down. Now, here's the philosophical thing I want to kind of pose to everyone, right? This is the cumulative number of excess deaths, right? So if you look at the US and where we are compared to Italy and the United Kingdom, we're over the 2,000 mark, meaning that 2,000 out of a million people have died as a result of COVID here in the US that it was not estimated to or projected to die with our trend since before the pandemic, right? So again, simply put, 2,000 people, more than 2,000 people per million are dead now, right, on average, than compared to what was expected in 2020 into this year. So philosophically, the question is this right? And I've heard arguments from professionals on both sides, right, in terms of how much should we be doing to mitigate risk regarding COVID and why? And to me, this is why we should, in terms of to prevent these excess deaths from happening. But there are some who may argue differently, but I only want to present you the data so you can determine how much to put behind the rigor of prevention in regards to what's happening here in the US in your workplace as well. So let's now get into the framework of the risk and cost, right? Explaining the likely downstream clinical and corporate impacts of our decision making in terms of keeping compliant as well as mitigating risk for today and tomorrow. That's what we're after, right? And I can't beat this up enough. Herd immunity not happening. Just want to mention it again so that we have no misnomer in regards to whether or not we're going to be on the other side of this as a result of this percentage of people outside of that have been taken out of the susceptibility pool. Ain't happening, right? So now let's look at then where we were a month ago in terms of vaccinations as we break that number down into at least one dose and fully vaccinated. We were at 61, almost 62% and 52% for everyone, including if we break it down to just over 12, 72 and 61% is where we were. If we look at it a little differently, same metrics, but a little different presentation here from CDC, we can see that for at least one dose as of today, we are now at 65% for the total population, 76% for over 12. Fully vaccinated, we're at 56% and 65% for over 12. And we're tracking now, CDC is tracking now the booster dose. Not a high number of individuals have received a booster. Again, booster is recommended or has been recommended for those 65 and older, as well as those with pre-existing conditions that make them more vulnerable to poor outcomes for COVID. And we do not have a recommendation for the entire population at this point. I know last time we presented and said that you should consider mandating the booster for your workforce, and in accordance with recommendations from CDC and FDA, obviously, particularly those who are at risk, 65 and older, as well as those with pre-existing conditions. And we'll talk more about the booster towards the end of the presentation here today. So let's move into our framework here. This is what we talked about many, many moons ago, right? In terms of 3 levels of prevention and our thought towards preventing COVID transmissions in the workplace. Primary, secondary, and tertiary prevention, you're accustomed to that methodology or that frame of thought in regards to how we keep people safe from a preventative standpoint, right? So we want to carry on that frame of thought into our strategy of COVID risk management. And so the tertiary prevention regarding COVID risk management is going to be, COVID-19 monitoring, recovery, and return to work, right? and that's actual managing disease, those who have positive COVID cases. The secondary prevention is early intervention for workplace to prevent workplace transmission. Obviously, we've been after this for some time in terms of our strategy, but we want to continue to understand how we can recognize early symptomatology and keep people home safely. But primary prevention is really where some of the debate is right now, right? And where our cost and burden is going to be for some time to come, most likely. So the workplace wellness aspect of it should be a consideration, and that's what we want to continue to introduce. We mentioned it briefly last time, and I believe 2 months ago, and we'll double down on what we are talking about in terms of wellness and the impact. And we really want to focus in on leading indicators for COVID-19 transmission risk as well as poor outcomes. And so this is the framework we presented, I believe, some time ago here. And it's a philosophy of safety to wellness, right? Our EHS professionals really focused in on not just the classic safety paradigm, but also how do we get to a population of wellness? Let's call it the total worker health, if you would. But what are the tools? What's the methodology to get there? And we won't spend too much time here, but I wanted to represent it here again with the measures on the left-hand side, according to the safety paradigm that we classically have been used to and leveraging. And then again, going to the wellness piece of it with survey-driven data that's subjective so that we can to manage holistically a risk reduction in the workplace for our population, right? And so when we break this into our framework for cost, as we look at our risk analysis here, we want to talk about talking about vaccination mandates, mask mandates, social distancing. And when we are speaking to these mandates, it's not necessarily saying you need all these mandates in place. We want to speak to which mandates will be most efficacious from a safety standpoint, as well as from a cost mitigation standpoint. And when I mention cost, I'm not mentioning only one facet of cost, right? And we'll continue into this. Secondary prevention, early symptomatology, right, is what we talked about, but we're talking about screening specifically, right, doing the daily symptom screening. This is likely to be a long-term play, right, that it's something where we're going to continue to have to screen and keep people with symptoms out of the workplace for the next 5 years, if not in perpetuity, it seems these days. And then thermography, this is up for debate, right? I have yet to speak with a substantial number of positive thermographic evidence of people showing up with fever, right? Most of the time, it's talking with EHS professionals and saying, out of the time that we've been doing infrared thermography, we may have had 1 or 2 individuals, right, out of hundreds, if not thousands, that actually presented with a positive screening thermography-wise for fever. So it's up for debate. Do you keep it in place in terms of infrared cameras? Or certainly considering the phasing out of staff, thermal checkpoints and whatnot, is something we should be thinking about from a cost perspective, right? And so again, not at this point suggesting one direction or the other, but only consider what the framework is for understanding our analysis. And then testing is the other piece of this in terms of secondary prevention, doing surveillance testing as well as diagnostic testing. We're all used to both at this point in time, and particularly diagnostic testing for those who are symptomatic, right? So we can get those early symptomatic individuals out of the workplace, home safely, and into the return to work process, right? But the surveillance piece is what specifically the executive order and OSHA is now contemplating making mandatory for everyone, right? And we'll see how that promulgation continues. And the impact that it's going to have for our workforce from a cost perspective is the framework we want to think about. As we look at then the tertiary prevention management aspect of it, we must consider our COVID-19 direct healthcare costs, right? What does the hospitalization cost look like from a severe illness standpoint? What's the burden there? What are the indirect costs from the presenteeism standpoint? And we know factors that play in the presenteeism: stress, sleep disturbance, for example, and then the absenteeism, the anxiety, the depression from a mental health standpoint plays into the absenteeism, right? And so these are the items. This is not the most comprehensive, right, present in terms of our analytics, but this is going to get us into thinking differently about how we address our workforce and consider then what tools do we have at our disposal in order to get at modifying these risk factors as well as mitigating costs. So when we talk about then the trends in terms of expectation in clinically in the workplace as well as in the community, what are the trends that we want to look at from an injury standpoint and overall poor health standpoint that are directly or indirectly linked with COVID-19? And we want to speak to what the insurance industry is well attuned to at this point, right? Which is the indirect costs that arrive at or hitting the pocketbooks of the insurance companies, as well as those self-insured employers, obviously, as a result of this pandemic. And if we look at some of the statistics in this industry, in the insurance industry, that they're identifying, one of them is musculoskeletal disorders, right? For example, roughly 34% of the injuries we see in the workplace from a lost day standpoint, right, are musculoskeletal associated. And we saw in 2020 an increase in this metric, okay? And we know that according to the mutual, the index that is put out that was just published a couple of months ago, $58 billion was the number spent on musculoskeletal disorders in the workplace in 2019, right? And so we want to be cognizant that this is going to be a substantial impact to our workforce, and the drivers behind it being what COVID has done to the workplace. And that's working from home, sedentary work, increased stress, right? And a lot of hunched over the computer to do video conferencing, right? And this is a setup for increased a surge in musculoskeletal disorders. And so we have to anticipate this increase and the impact it's going to have from a cost standpoint directly from a healthcare outlay, as well as indirectly for our worker population, right? And the labor shortage is impacting this as well. We know that the standards for overtime have been challenged, and we know that workers have, because of their overtime, resulted in an increase in musculoskeletal disorders, as well as injuries in the workplace. And if we continue into some of the statistics, we can look at then 89% of the workplace safety experts that are saying our essential workforce, and we're expecting increases in musculoskeletal disorders, if not, in some cases staying the same, but definitely increases for 2020 and 2021, right? Fast forward to what the American Psychological Association has said, 61% of Americans have undesired weight gain over the course of 2020. Again, because of the nature of how work has shifted into a sedentary, for many, a sedentary phase, right? And so again, when we talk about the impact of this, we know that individuals with a BMI index of 30 to 35 have an increase in both chronic illness like arthritis in the knees, as well as injuries in the workplace, right? Injuries on the job. So again, these are all indirect costs as a result of COVID-19 that we have to be thinking about and has to be a part of our mitigation strategy if we're to, in the months to come in into next year, help prevent a spike in costs as a result of COVID-19. Moreover, if we're talking about the trends we saw in absenteeism, right? More than 2 million employees, during the month of April last year were out because of illness, and that was a record, okay? And if we look at then overall, twice as many people were out in 2020 as compared to 2019 over the same period, right? And so we again know that COVID-19 has had a dramatic impact on absenteeism as well as presenteeism as we talk about mental health. And some of the statistics around mental health, including PTSD, for example, we know that a lot of workers will experience PTSD. Over 70%, and this is not in this particular journal, but over 70% of the work of individuals in general population will experience trauma in some way, all right, during their lifetime. and that will impact their presenteeism at work and their productivity. And so we need to be cognizant about how do we reduce the burden and cost on the workforce so that we can mitigate risk and, again, hopefully have a healthier population, a less costly population moving forward. And we're going to talk about then what the fix is not likely to be, right? And we'll be brief with this, but we have to mention it so that we can distill any myths about what the end all be all will look like on the other side of the pandemic, right? And so we simply put, turning to intervention, clinical interventions won't be enough, right? And if we look at the vaccine itself, we have data recently published that may give some silver lining to some, right? But I want to caution against looking, be careful in what data you're consuming to arrive at your conclusions about effectiveness. This particular article was published September of this year, just recently, September 22nd, and it took 1,482 participants, all in healthcare, right? In terms of the impact, and looking specifically at the impact of the Pfizer vaccine and the Moderna vaccine. And what they found is that even partial vaccination provided protection for these workers, this subset of workers, 77.6% for Pfizer and 88.9% for Moderna. Okay. If you look at the effectiveness at a full vaccination, it was 88.8 and 96.3%. For this population, again, I want you to be cognizant of that, that this is not to be extrapolated to the entire workforce, right? We know that for this subset, the effectiveness was lower 9 to 14 weeks after full vaccination versus more recent or more closely to the vaccination, 3 to 8 weeks. So that speaks to the waning of the immunity or effectiveness of the vaccine. But we want to make sure you understand when you read data like this, it should be in context that the vaccine effectiveness reported in this is the New England Journal of Medicine, reported here, is only specific to healthcare workers, right? These are workers who are wearing PPE, doing practicing as much as one could, best practices to help mitigate COVID-19 transmissions. And so, again, when we see data like this, don't take it as it's going to be the answer to what is coming for us in the general population, in the general workforce. Another example of what not to believe to be the panacea for everyone is clinical intervention with medication, right? We talked about ivermectin last time and presented on its use and its non-approval at this point for its use. Today, we want to talk about, since we met last, a new medication that was presented by Merck, right? And this medication called molnupiravir has been shown to be effective for reducing severe illness and hospitalization. And we want to zero in on this as, again, a solution for mitigating some risk, but not a lot, right? When we're talking about the entire workforce. So what am I speaking about? I'm speaking about the results that show this drug was effective at reducing hospitalizations by 50% or death by approximately 50% as well. So it took 7.3% of individuals who were in the experimental group and took the medication down from 14.1% who took placebo, right? And the other underlying benefit here that we saw was that there were no deaths in the experimental group, those who took the medication, right? So effective medication for the treatment of COVID, yes, absolutely. But in context, again, only for those individuals, according to the study, that had a pre-existing, at least one pre-existing condition, right? Meaning that they had a risk for a pre-existing condition for poor outcome, meaning that they had a risk factor for poor outcomes such as age, 65 and older, or diabetes, history of cancer, etc., right? And so for the at-risk populations, this medication may be very efficacious for helping decrease their risk of hospitalization and severe illness and certainly death, which in turn will be a benefit for us in terms of mitigating risk to our populations that have these pre-existing risk factors, right? But again, it's only a small subset of the worker population and not a panacea for everybody, right? So when you see this in the news, recognize where it belongs in terms of in context. The other last thing we'll talk about here in terms of, yes, it's a part of the solution, but not the overall end all be all, is the approval of vaccinations both for those 12 and under, as well as for boosters for the at-risk population. So FDA has said that they are going to meet now on October 14th to consider the both Moderna and the Johnson & Johnson vaccine for boosters for those individuals who are at risk. So they'll meet on the 14th and 15th to recommend the boosters. Right now, the boosters are only approved or recommended for the Pfizer vaccine, all right? And then when they meet on the 25th, they're going to consider the vaccines for all three vaccinations for those 12 and under. And that will certainly play a role in helping us mitigate transmissions in the workplace through limiting the susceptibility for kids to an extent. But again, not the answer to all of our woes. We have to still be broader in our thoughts around how to mitigate risk. And obviously, we want you to be thinking about not just COVID direct cost and risk, but indirect, right? And overall health and wellness as we move forward. So the goal in terms of our messaging really is to present a balanced, safe approach in our mandates today, tomorrow, and for everyone, right? And it will certainly include, right, messaging such as, yes, the boosters that are yet to be recommended beyond Pfizer have been shown to be safe, right? That in this particular study that was published September 28th, a Pfizer booster, 306 persons, showed the same amount of side effects as those who received the booster compared to those who only received their second dose previously. So there were no increase in adverse events as a result of this third dose of the vaccine. So that, yes, this will be a part of our messaging, particularly for those at risk at this point in time, to help keep them safe in the workforce, right? And there's an OSHA mandate, right, for each employer to keep those at risk safe in the workplace as well. So we'll talk about more of this strategy, but we're also going to talk to, in this case, the numbers for next time. And so with that, I will stop here and we will keep the framework to the point of COVID risk management, right? From a tertiary, secondary, primary prevention, and we'll dare to go beyond just COVID and talk about health risk management and associate the numbers with the health risk management for our workforce in part two. So part one, we presented today. I'll change this to part two here when we talk about the numbers associated with this risk mitigation strategy and the impact to our workforce. So we'll stop there. We'll take questions for the next 12 minutes here. Thank you so much.
Thanks, Dr. Harris. Can you hear me? It's Karen.
I don't know if we had Karen join us again here. Alexis, if you're on,
you can't hear me?
if you don't mind reading questions.
I can hear Karen, but I think for some
reason
reason.
Okay, go ahead and jump in, Alexis.
Okay.
I'll remute.
Not a problem.
So we'll jump down to questions here. I'm able to see them. So let's jump to some of the Q&A. So we have here a question in regards to studies. So there are a lot of pending peer reviews or studies that regard natural immunity versus vaccinated immunity. Should employers be creating any policies or practices that recognize some unvaccinated individuals have immunity? So the answer to that is yes, absolutely. And we know that individuals who have recovered from COVID within the first 90 days thereafter are drastically unlikely to have a second episode of COVID infection, right? So within that 90 days after an event of COVID, you should, in any circumstance of another encounter with COVID or exposure, not need to quarantine, and certainly not need to be isolated, because again, likelihood of transmission secondarily is low. So in that regard, that policy should be in place for all employers across the board. When we're talking about then beyond 90 days, there is increased risk for reinfection. Now that is low. If we look at the updated data as of August of this year in regards to US presentation of a second infection of COVID-19 after recovery, it is below 1%, 0.9%, right? So again, very low occurrence of reinfection after recovery beyond 90 days. Now, beyond 6 months, that number theoretically goes up. To what extent, we don't have much data around in terms of reinfection rate beyond what we saw after 90 days. So the policies should go back to to mirroring those individuals who are unvaccinated and have not received and have not had an infection of COVID-19, right? So just to recap that, within 90 days, yes, policy should be different. Beyond 90 days, policy should revert back to what the general approach is for the populace of unvaccinated individuals. Next question, is there a quantitative antibody test that we can recommend to employees who are asking us about whether they need a booster shot? I wish the answer was yes to that, but unfortunately the answer is no, there is no quantitative antibody test. There is a semi-quantitative antibody test. So what do I mean by that? The semi-quantitative test was first approved by the FDA in November of 2020 in terms of the technology and the approach from a laboratory standpoint. And it's something that is offered widely by Quest. It's offered by LabCorp as well as many other laboratories. But that test does not give us enough information to understand who at this point in time needs a booster or not. Now, if you've heard any of my recent news broadcasts on Newsmax or some of the other outlets, you know that I am a proponent for understanding who needs a booster and then recommending a booster to those individuals in the general population without pre-existing conditions that put them at high risk for poor outcomes. But unfortunately, that technology does not yet exist so that we can understand what the titer, it's called a titer when we're talking about these blood tests, what the titer actually means from a safety perspective. Now, there are studies doubling down on understanding the significance of neutralizing antibodies, right? And hopefully over the next several weeks to months, we will have enough data to understand what these titer levels mean for each individual in regards to their relative protection to a transmission event of COVID-19. Another question here, we'll jump down. Vaccine efficacy wanes over time. How many months out following vaccination should employers consider that employees may need a booster shot? The answer to that is 6 months, and that is for those individuals currently at risk for poor outcomes, again, age 65 and older, pre-existing conditions. It's not recommended across the board yet to have a booster for all comers. We'll see what FDA recommends for Moderna and for Johnson & Johnson on the 14th and 15th. And then beyond that, they need to regroup around whether or not to recommend boosters for all comers. Next question, can we consider people fully vaccinated if they've mixed 2 mRNA vaccines? So in practice, yes, right? There was evidence out of the UK of admixing the Pfizer and the Moderna vaccine, and one, not showing any safety issues, and 2, showing still good efficacy at protecting from not just to a low extent transmissions, but also substantially for decreased hospitalization and severe illness. There is more data coming out in terms of mixing for booster purposes, and that is what also FDA will consider this month during their meetings. Next Excuse me, next question. Lambda variant seems like it is not escaping the US approved, Lambda variant seems like it is not escaping the US approved and authorized vaccines. Can we make that conclusion after 2 to 3 months of the variant being present in the US? So all the evidence that it has been conducted by the pharmaceuticals, both Pfizer, Moderna, and Johnson & Johnson, have shown efficacy against the Lambda variant and Mu, as well as Delta, obviously, in regards to efficacy of, again, preventing severe illness and hospitalization. There is still no evidence to suggest that its efficacy to prevent transmission is higher than, against Lambda in particular, is higher than what we've seen against Delta. So I reference always back to the data from Israel showing 39% efficacy at prevention of transmission, which does coincide with what we're seeing anecdotally in the industries, across industries for breakthrough infections at this point in time. How is it determined that Delta is now the predominant strain? It's all done through genetic profiling or genetic testing and sequencing. So laboratories have now the assays to do the analysis here in the US and abroad at various laboratories to understand the genetic profile of the COVID strain that individuals are testing positive for. And as a result of learning those particular genetic strains is how we know it is Delta causing the predominance of positive cases. Let's see, let's skip down here. Can you speak to what's happening in Israel, vaccination rates versus case rates? So we know Israel is a leading country for fully vaccinated individuals, over 70%. And they did see a spike in cases as a result of Delta, which again speaks towards the lower efficacy of prevention from vaccination. They vaccinated with primarily Pfizer, and we know that again, efficacy of prevention of transmission was low, 39%, but the prevention of hospitalization was 88% and severe illness was 92%. So it was mainly attributed to the low rate of efficacy for prevention is why we saw the spike in cases in Israel, similar to what we saw here in the US. All right, we got time here, looks like for one more question, then we need to wrap up. Let's see, how would countries that have very high vaccination rates, such as Israel, and I believe Iceland, compare on the graphs presented in the trends analysis? I have presented that comparison before. I can present it next time, but it does, the trends are the same or are very similar in that Israel did have a spike as well as we did at the same, just before we did actually. And again, that spike was on cases, not the mortality. We had the spike in mortality, the UK and Israel did not, right? And that was because they had higher vaccination rates, most likely. All right, since we answered that one pretty quick, let's sneak in one more question here. If a person received, no, we'll do the next one here. To what degree do you think employers still need to focus on surface disinfecting on high-touch areas, shared tools, etc.? Have there been any recent studies about how long the various variants survive on surfaces? So I have not seen any evidence specific to the variants and their longevity of survivability on surfaces compared to the wild type variant, the wild type COVID-19 or SARS-CoV-2 that we saw in days of old. We do know that the virus itself can exist on surfaces for hours, right? And we do know that contaminating your hand and then rubbing your mucosa, right, from an infected individual can produce a COVID-19 infection. But the rate of that that we've seen is far lower than what we expected. And the primary means of infection at this point is through aerosolized droplets. So whether or not that means you need to stop disinfecting is relative to the level of high touch, right? So if you have areas where there is adequate time in between the high touch areas for the surfaces to become less burdened with infected droplets, meaning that it's several days in between use, then you may not need to disinfect that area in particular, right? But if you have rapid and continuous use of high touch areas such that the likelihood of contacting viable pathogen is still there, fomite, we call it, then you may need to still continue your disinfection processes to help mitigate risk for transmission in the workplace. Without going into too more detail, because of interest of time, we'll leave it at that. We can address more in the typed responses to all those questions that we weren't able to get to during this presentation. But I'd like to thank everyone for joining us once again. And we look forward to part two. Discount the screen here. So part two, next time, we'll talk about the numbers for cost and risk. And we'll talk more strategy on how to mitigate as such, so that we can continue to expand our thought on keeping the workplace safe as possible from COVID directly and indirectly. So with that, again, thank you. God bless, be safe, and we'll see you next time.